Hey guys, I'm going to go ahead and record some content for you for this week. We will not officially have class, but I'm going to post this online so you guys can take a look at it on your Canvas. I have a few different topics that I'm going to go over with you that is on your syllabus, as far as tuberculosis and upper respiratory tract disorders and that type of thing. So I'll go over some of that stuff with you, and hopefully that'll help a little bit. So make sure you watch that this week and let me know if you have further questions. Give me 1 second here. Okay, I'm going to pull up the PowerPoint if I can. Okay, so these are PowerPoints that I made for my other class. I'm just going to go through the topics this way. Oops. Let's see if I can get back. There we go. So anyway, this first topic is just about tuberculosis. We'll talk about that first, and we'll kind of go from there. So with tuberculosis, this is a contagious bacterial infection that's caused by Mycobacterium tuberculosis. It can affect your lungs mainly, but it can also affect other areas of your body too. So things like the kidneys, the brain, the spine, the joints, and the liver. This is an acid-fast type of bacteria, so it stains bright red and an acid-fast staining smear. So like on this picture here, you can see how the bacteria itself is red. This is an aerobic bacteria, so it loves oxygen and it must have that to grow, which is why TB mostly affects that upper portion of your lungs, because there's a higher oxygen concentration there rather than at the base. So how is this spread? So typically this is spread through the air, through droplets. So you're supposed to wear, a respirator at all times when you provide any kind of patient care to this patient. So usually this patient is put in a negative pressure airflow room, so they have to be in there by themselves. And then every time you go in to take care of them, again, you have to have that special mask on. It's called an N95 mask, and it has a respirator built in it to kind of protect you from those bacteria. The thing is with this, the bacteria is very small, so it can suspend itself in the air. It's different than any kind of droplet kind of infections because if a person with active TB talks, coughs, or sneezes, or laughs, or yells, or something, you can cause someone to inhale this inadvertently because of that. You have to be in contact with the person for a period of time to catch tuberculosis. So this is why people who live in close quarters or spend a lot of time together are at risk. So if you think about it for a second, think of some people who would be at higher risk for TB. So it would be like, if you live in close quarters, this would be things like prison systems. Or if you were at college, living in dorms, areas like that, those people are going to be at more risk. So again, with the risk factors. So with the tight living quarters, long-term care facilities would be at risk, homeless shelters. Those would be a couple others to add to our list. And then if you live below or at the poverty line, so maybe you're homeless, you're going to be more at risk. Any type of refugee has a high incidence of TB in their home country, they're going to be more at risk. If you use IV drugs, you're going to be at risk. Substance abusers. If your immune system is already low, like maybe you have HIV, then you're at risk. And then also any kids less than age 4 to 5 with a weak immune system are also going to be at risk for this. Okay, so there are two different versions of TB. There is latent TB and active TB. Latent means that this this person has TB, they've been exposed to it, so it's in their body, but they don't currently have active signs and symptoms. So what happens is this bacteria gets into your system and it just lays dormant for years and years sometimes. So this person, if you did testing on them, it may show that they've been exposed, but it doesn't show, that they have active symptoms. What your body does is when it gets inside your body tries to, activate your immune system and tries to fight it off and encapsulate it. So therefore, if you have latent TB, you're not contagious at the time. So no active signs and symptoms. You would have a normal looking chest x-ray and a negative sputum at that time. So the only thing is, this person might have a positive TB skin test or blood test if you ran that. So this means that the immune system has responded to the bacteria. And then on this slide, it says, hey, do they still need treatment? Well, definitely, yes. This will help prevent active TB in the future. So anyone that you would inadvertently find that they had latent TB, you would still treat because you don't want it to get to the point where it becomes active. According to the CDC, about 5 to 10% of patients who do not receive treatment for latent TB will develop active TB at some point. All right, so then when we talk about active, this is, hey, your immune system isn't able to contain it, so the bacteria takes over. So typically when someone has this form of TB, it's usually because their immune system is down. So, hey, maybe I already have HIV, or maybe I have cancer and I'm doing chemotherapy, so my immune system is low from that. Like anything along those lines. As we age too, older adults are more at risk because as you age, your immune system gets not as effective anymore. So when you have active TB, you are contagious. So you will have signs and symptoms that would make you think that you were sick. So you're going to have a positive skin test, that PPD. If they did a blood test, that would be positive. And you're also going to have an abnormal chest x-ray. And if they sent off a sputum culture, that would also be positive. So the thing is, once this gets into your system and it starts to activate, the bacteria can spread to other parts of the body too if it gets in that lymph system. So that's when you would start to see other areas get affected, like your brain and your spine and your joints. So you're trying to fix that so that this person doesn't get that. Okay, so when you do have active signs and symptoms, this is what you would see. A cough that lasts 3 weeks or more. You may be coughing up blood. You could have a fever, night sweats, fatigue, unintentional weight loss, chills, loss of appetite, chest pain, or pain with breathing or coughing. Now, I get that there's a big list of things here, but the thing that I do when I'm trying to learn different disorders is I try to focus in on certain signs and symptoms that you don't see with everything else. So if there's something that kind of sticks out to you that is different with this compared to other things that you've seen before, then I would focus on that. So for me, it was the cough that lasts 3 weeks or more, and coughing up blood, the night sweats, because you don't see that with everything. And then also where is it? You can get a fever with this too, but I mean, that's not really the big thing. So really the night sweats, the coughing up blood, the cough that lasts 3 weeks or more, those are the things that I kind of focus in on. All right, so when we test for this, so typically, if you were a healthcare provider, they would come into your office and they would be like, wow, I feel really sick. These are my symptoms. And so if you were the healthcare provider, you'd be like, oh, this person does not look too good. I'm going to put on a mask, to protect myself so I don't get it. And then I am going to test them to see if maybe they have TB. So one of the things you would do is a skin test. This is called a PPD or a MAN2 test. This is where they put purified protein derivative of that virus injected with a tuberculin needle in the inner part of the forearm. So after you inject this, your arm should look like what this one does on the picture. So it's going to have that wheel, that little bit of a bump there. So typically you want this person to come back in, 48 hours or so to get it read. And the problem is if you do this test, there's certain patients that just aren't real reliable and they just won't come back. So, you pretty much need them to come back in 48 hours to know. So with this, a Mantoux skin test will tell you if you've been exposed to TB. It won't tell you if you have it for sure or not. If you have an induration of 10 millimeters or more, your test is positive. This test does not confirm if you have active TB. Like I said, you have to do other things to confirm that. But what an induration is it's a palpable, raised, hardened area in that area where you gave the shot. So you actually will measure it, and that's what I'm talking about by 10 millimeters. So you're going to look at it like that. Again, you need to read the test in 48 to 72 hours. If someone's not real reliable about coming back, then maybe you would want to do a different type of test to make sure. A positive result doesn't mean that you have an active infection. It just means that you've been exposed to it. And again, you can't tell the difference if this was latent or active with this. So if you get a positive result from this TB skin test, typically the next step is to do a chest x-ray. All right, so as far as testing goes, there are other things that you could do if you don't have a real reliable patient to, come back to get that test read, that skin test. So there are other things. There's something called a quantiferon TB Gold and also a T-spot. These are blood tests that will check for the immune system's reaction to this virus, or this, not virus, the bacteria. So the nice thing about this is it's just one visit. They don't have to come back to get their results read, and you'll know, if this is a thing or not. The downside of this test is it doesn't differentiate between active or latent TB, and the person will need to get a sputum culture and a chest x-ray to confirm if they have TB or not. So in other words, if you get this blood test, it may come back positive, but you still can't say at that point that they are positive for TB. You would have to do some other things to confirm. Okay, so the best way to confirm if someone has TB is to get a sputum culture. The sputum will have that Mycobacterium tuberculosis in it, and you will just test for that, and that's going to tell you if they have it or not. The problem is with the sputum culture, it takes a while for your results to come back. So typically if you get it, you're going to be waiting like 3 or 4 days or whatever to get your results. So, and the other thing too is sometimes when you ask someone to give you a sputum specimen, they don't give you a good one. So that would be the other downside of this. But again, with this sputum culture, if it's sent to lab, they're going to stain it with a special dye, and it'll appear like a bright red color if it is positive. It's best to collect the sputum in the morning before breakfast because you have a lot of secretions from overnight, and that's like a really good time to be getting it. Now, a lot of people think that, hey, I get the skin test, it's positive, it means I've been exposed, so my next step is to go get a chest x-ray. A lot of people think that the chest x-ray is diagnostic of TB, but it's not, because I've looked at a lot of things and it's said that, yeah, maybe they think you have TB, but again, they would still have to confirm it with a sputum culture. That's the best way to find out. Sometimes like a radiologist will read a chest x-ray a little different compared to another radiologist. So there is, some error there. So the best way to know is that sputum culture. Okay, so earlier we discussed how you would do airborne precautions for this patient. So you would put them in a negative pressure room with the door closed. You have to wear that N95 mask when you provide care. You have to do really good strict hand hygiene. If the patient has to go anywhere for testing, like say they have to go down to radiology for something, you would try to avoid large groups of people. So you would put a mask on the patient, and then you would probably try and take them down the back elevators or something to keep them away from a lot of people. Okay, so as far as nursing interventions go, active TB infection education is crucial. So most patients are treated outpatient because of the duration of how long they have to take the medication. So just because you have someone in the hospital that has active TB doesn't mean that they're going to stay in the hospital the whole time they're getting treated. That's just not feasible because it's a long period of time. So they will typically send someone home. You have to be able to tell them that they need to isolate themselves at home. So they can't go to work, they can't go run errands, can't go to school until they're officially no longer contagious. So you can only go to medical appointments and you have to wear your surgical mask. Um, to be removed from isolation, they will need to be on medications for about 3 weeks. They need to have 3 negative acid fast sputum cultures. They also need to have an improvement in their signs and symptoms and also be taking medications exactly like they were ordered. Because TB can become drug resistant. So if you didn't take your things for as long as you were supposed to, or you just quit, then it can come back with a vengeance and it can be very hard to get rid of. You should not be having visitors. You know, if you're at home isolating yourself, stay in a separate room from other family, keep away from young kids, keep your windows and doors closed so you're not spreading it to others in your neighborhood. If you are coughing and sneezing while you have this, try to dispose of your tissues in a certain way so that you don't spread it to everyone else. So treatment for this is typically 6 to 9 months. You'll see a little bit of a slight difference in certain, books about, and maybe it's a little bit longer. It just varies. So typically there are 4 different antibiotics that we have to choose from for TB. And I'm going to go over those real quick. So pyrazinamide is one of them. This has a bactericidal effect, so it will actually kill that bacteria. You're supposed to watch patients who are diabetic or people who have kidney problems when they take this. They may be more at risk for gout, so it's going to increase their uric acid in their body. So while they're on this, you should, draw uric acid level occasionally and also watch their liver and kidney function. Take it with food. Ethambutol is another one. This can stop RNA synthesis and it's bacteriostatic. So it stops the bacteria from reproducing. So as you can see with a lot of these different antibiotics, they cause some pretty serious symptoms. So a lot of times that's why people stop taking them because of that. So the really big important thing to remember with TB is to make sure that people take their meds like they're supposed to and don't stop. Even if they have symptoms, you just encourage them to report their symptoms to you, and then you try to deal with symptom relief. Okay, so with ethambutol, it can inflame your optic nerve, so it can cause vision problems. So you have to get your eyes checked regularly while you're on it, and you can also get peripheral neuropathy. So you can have numbness and tingling and stuff in your hands and your feet. Rifampin is another one that they could take. This kills the bacteria by stopping the RNA polymerase. You need to educate about this drug will turn the body fluids orange and it can stain things. So like if you wear contact lenses, it can stain those. So you need to wear hard contact lenses instead. It can make birth control less effective. So they should use a backup method. They can sunburn easily while they're on this. They should not drink alcohol while they're on this because it can cause problems with their liver. Isoniazid is the 4th one. This kills the bacteria and stops its growth. So again, this one can decrease vitamin B6 levels. You can have numbness and tingling in your extremities. You can have problems with your liver function, and it can also cause neurotoxicity. So it could cause a change in mental status. So pretty significant things can happen to you while you're on this. So you have to be really careful. When I say that it can cause liver problems, some of the things you might see would be things like jaundice, anorexia, malaise, nausea, fatigue, that kind of thing. So that's kind of what you're going to be watching for with these. And then this last slide talks about streptomycin sulfate. So if you do have someone who stops taking their meds like they were supposed to, and they still have TB and they come back in to get treated, they're going to have drug-resistant TB at that point. So if you try to put them on any of those 4 meds, it's not going to work like it did before because they stopped their treatment before they were supposed to. So streptomycin sulfate would be a last resort of something that you could use if they had drug-resistant TB. The reason it's a last resort is because it's pretty strong and can cause lots of problems. So what it does is it stops protein synthesis and it kills the bacteria. But you can have problems with your hearing. You can get ototoxic from this. So you have to be super careful with this medication. You also want to monitor urine output and renal function while they're on this. It just can, not be good. You can get toxic while you're on this medication, so you have to be very careful. So again, the biggest thing I want you to get out of this TB stuff is that, yes, you can have active or latent TB. If you have latent and someone, like your physician finds out that you have that, they're going to treat you for it, even though you're not having active symptoms, so that hopefully later on in life you won't end up getting it, getting those active symptoms. You can die from this really easily if you didn't get it treated, especially like I don't know if you guys remember back when we talked about HIV and AIDS, that's a big thing. If you get TB while you have HIV, you could totally have huge problems from that. So definitely a big deal. So the thing is, you have to treat this with antibiotics, and usually it's more than one that they have you on at the time. You will be treated with this usually over months, like 6 to 9 months. And you are considered contagious until you get those 3 negative sputum cultures and your symptoms are better and that kind of thing. So just kind of remember that about TB. All right, let me see here. Okay, a couple other things that I want to talk about. On your syllabus, it talked about some upper respiratory disorders. So I have a thing about that I'm going to talk to you about real quick. So allergic rhinitis is part of upper respiratory things that go on. Basically what it is it's inflammation of your nasal mucosa. Usually it's because you have a virus or a bacteria that caused it, or maybe you have allergies and the allergies is what caused it. So when you have rhinitis, it's usually just a runny nose, nasal congestion, and itching or sneezing. One of the most common things that you see with this is postnasal drip. So that can cause a sore throat, cough, and throat clearing. So treatment for this is to try and avoid allergens if you know what you're allergic to, and to take some over-the-counter medications to help with your symptoms. Surgery would be a last resort to correct any structural issues that might be causing your problem. There's a bunch of different things you can do to cut down on allergens, on a normal basis at home. So like they have air purifiers and sweepers with hypoallergenic filters. You can get special bedding that's supposed to, keep the allergens away. And then just do frequent house cleaning to kind of keep away from dust and stuff like that. So that would be very helpful. And I'm sure we've all had the common cold before. That's part of the upper respiratory disorders. So this is pretty much that rhinitis that we were talking about, but it also goes a step further. So this usually you get from a virus. So it runs its course and then you get better typically. You get this from droplets in the air from people sneezing, coughing, or by direct contact. Really, there's not a whole lot to do for a cold. You just kind of treat symptoms and get lots of rest and drink fluids. So they say to encourage rest, 8 to 10 hours of sleep a day, encourage fluid intake, and then promote proper disposal of tissues and cough etiquette. When we say cough etiquette, this means cough in your elbow or not in your hand, because your hand's going to spread it to everyone. Also, if you encourage a home humidifier or just breathing steamy air after a hot shower, sometimes that makes you feel better from some of your symptoms. Things that you might take to help with your symptoms would be antihistamines. The antihistamines would block the release of chemicals from white blood cells that bind with receptors in your nasal tissues. So stuff like pseudoephedrine, that would be an antihistamine. Decongestants, so if you're real stuffed up or something, we're gonna take those. That would be like phenylephrine. It's gonna constrict your blood vessels and decrease the edema that you're having. There are also nose sprays that are glucocorticoid sprays. This would be like your Flonase, if anyone takes Flonase over the counter. This would be something that you would take daily. It's not something you would reach for an acute problem because it's not going to help right away. But if you take it daily for a certain period of time, it usually helps you quite a bit. Antipyretics in case you have a fever, and then antibiotics if your infection is from bacteria, because only bacteria will be treated with an antibiotic. So common cold is also called acute respiratory infection. You can see things like that rhinitis, like we were already talking about earlier, and also a sore throat with this, and sometimes even laryngitis, where you lose your voice. Colds are highly contagious because the virus is shed for about 2 days before symptoms appear and during the first part of the symptomatic phase. Symptoms can last for as long as 1 to 2 weeks with the common cold. When we talk about sinusitis, which I don't know if any of you have had that, but I know I have, and it's very uncomfortable. So what this is, it's inflammation of your mucous membranes of one or more of your sinuses, usually maxillary or frontal sinuses. So if you were looking at my face, like right up in here, in these areas. Swelling of the mucosa can block drainage of secretions, and it can cause a sinus infection. So some of the things you might have with this would be nasal congestion, headache, facial pressure or pain, worse when you tilt your head forward, cough, bloody or purulent nasal drainage, tenderness to palpation of your forehead or like around your eyes or facial areas, and low-grade fever. A CAT scan or a sinus x-ray can confirm that you have this. So usually sinusitis is going to follow you having a cold. Like you've had a cold and then all of a sudden you get this. So it's an exacerbation of allergic rhinitis, usually about 10 days after, something like that. When the sinuses can't drain, it provides a great place for bacteria to grow. So all that drainage just kind of sits there in your sinuses. So if it's not treated, it can lead to a mucocele. This is a cyst of the paranasal sinuses. Or it can even lead to osteomyelitis. And this is where you're going to end up needing surgery. So, because you get an infection in your bone up there. So, super important that you get this checked out. This picture kind of shows you where these sinuses are. The frontal sinuses are kind of right above your eyebrows, and then the maxillary sinuses are right on either side of your nose. So that's typically where you get those problems. Usually sinusitis is treated with a 5 to 7 day course of an antibiotic. Antibiotics only are prescribed for fever and symptoms that persist for at least 10 days or worsening symptoms following a viral respiratory illness. The reason that we're kind of particular about giving antibiotics for this is because of antibiotic resistance. There's so many people who get that. So you want to stay away from just prescribing antibiotics unless you absolutely need them. All right. One of the antibiotics that they typically will give for this is amoxicillin or Augmentin. That's usually the drug of choice for this. I don't know if you guys have ever taken that before, but it's huge. This pill is humongous. For people who are allergic to that, they could put them on doxycycline or Levaquin or Avelox. So those are a couple others that they might use. Again, you're going to treat some of their symptoms as well. So you could put them on pain relief or have them do sinus irrigation with saline nasal spray or something like that. And then I have a picture here of a neti pot. So a neti pot is something you can get over the counter. This will help like clean out your sinuses from all that drainage. And a lot of people really swear by it, say it's really good. But you have to be careful. If you don't get all of that drainage out and some of that water just sits up in there, you can get infected as well. So some weird things can happen with that. So you have to be very careful with what you're doing. Influenza is another part of the upper respiratory tract, problems. So seasonal influenza or the flu usually happens in the fall or winter months. It is a highly contagious acute viral infection that occurs both in children and adults. Initially, the flu can seem like the common cold. You have similar symptoms, runny nose, sneezing, and sore throat. But colds usually develop slowly, whereas the flu tends to come on suddenly. And although a cold can be a nuisance, you usually feel much worse with the flu. Common signs and symptoms of the flu would be a fever over 100.4, aching muscles, especially in your back, arms, and legs, chills and sweats, headache, dry, persistent cough, fatigue and weakness, nasal congestion, and sore throat. Usually the flu is going to be diagnosed with a nasal or throat swab. I don't know if any of you have gotten the chance to do that before, but it's an experience when you have to swab someone for this because the swab needs to go back so far and it'll kind of make them gag or feel funny, so it's kind of uncomfortable when you do that. So with the flu, this is different from TB because remember TB we said was airborne. The flu is just droplet precautions. So with this, usually you can get away with wearing gloves and a mask, and it doesn't have to be the N95 mask. It can be a regular mask. And the door to the room does not have to be shut. If the patient needs to be transported somewhere, again, you put a mask on them just like you would with a TB person and kind of try and keep them away from other people. But yeah, so droplet precautions are a little bit different. They say that you can't really get infected with droplet precautions unless you're super close to this person. So usually if you keep like 10 feet away from someone, you're fine. So people who are more at risk would be the very old or the very young. So adults older than 65, kids under 5, especially those under 2. Also, people who live in nursing homes and other long-term care facilities, people with weakened immune systems, people who have chronic illnesses, people who are obese, any of that stuff, that would be, people who are more at risk. Your best defense against the flu is to receive the vaccination. Whoops. Sorry about that. Here we go. Okay, so the flu virus travels through the air in droplets when someone, coughs, sneezes, or talks. And then sometimes you can pick up germs from just being on like a computer keyboard or a telephone or something like that. And that's how you end up getting it. The influenza vaccine is not 100% effective, but it is pretty effective. So it's also important to take measures such as to reduce the spread of infection. Always wash your hands, contain your coughs and sneezes, and avoid large crowds of people. Usually you will need nothing more than bed rest and plenty of fluids to treat the flu, but in some cases, sometimes your doctor might want you to be on an antiviral medicine. So there are medicines like Tamiflu or Relenza that are antivirals that you could take that might help shorten the duration of your illness so that you get better a little quicker. So for instance, Tamiflu, this is an oral pill. Usually you get it in 75 milligram dose, and it's done twice a day for 5 days. And typically that helps you feel a lot better. The medicine is used to treat people 2 weeks of age and older who have had flu symptoms for more than 2 days. If it doesn't prevent bacterial infections that happen with flu. It's not recommended for people with end-stage renal disease or anyone who's receiving dialysis. So again, it's not really going to like get you better quick, but it's going to shorten the duration of the time that you're sick. So usually, you know, it would help a little bit at least. Okay, a dose of the flu vaccine is recommended every flu season. And if you think about it, I know there's so many people out there who think that you can get the flu from the flu shot. That is not true. It's an inactivated virus. So this means that you know, you have this very small amount of a mercury-based preservative in it, and it's basically, when you get this, it's going to help prevent you from getting the flu, hopefully, in that season. The flu vaccine cannot prevent flu that's caused by a virus that's not covered by the vaccine. So like the people who make the vaccine, they try to predict the common things that they think they're going to see that flu season, and that's what they put in the virus or in the vaccine. But sometimes they don't predict quite right, and then maybe that year it's not as effective because they didn't predict good enough. It takes about 2 weeks for protection to develop after the vaccination, and protection lasts throughout the flu season. So anyway, it's a good idea to get it. It's not going to hurt you. It definitely will help protect you from getting super sick. The thing is too, even if it's not that effective that time that you get it, it still gives you a teeny bit of protection so that you're not as sick as you would have been if you didn't have it at all. People who shouldn't get the flu vaccine are these people here. So if you have severe life-threatening allergies, or if you've had, you know, like anaphylaxis or something crazy from getting a shot before, you should not take it. If you are allergic to egg products, that's a problem. If you've ever had that Guillain-Barré syndrome, because that can set you off, because remember we had a question about that on one of our tests. And then also, if you're not feeling well that day, you should just not take it. You should wait and take it when you're feeling better. Laryngitis is another upper respiratory problem that people can get. This is inflammation of your voice box from overuse or irritation or infection. So inside the larynx, you have your vocal cords, and normally your vocal cords they open and close really smooth, but when you have this inflammation of those, or they become irritated, you get swelling that causes distortion of the sounds produced by air passing over them. So it makes your voice sound really hoarse, or maybe you don't have a voice at all. So symptoms of laryngitis, again, hoarseness, weak voice or voice loss. Sometimes people get a tickling sensation or rawness of their throat, dry throat, or cough. So you can have an acute version of this or a chronic version. With the acute version, usually it's going to get better on its own. There's not a whole lot you need to do for it. Usually causes would be viruses or vocal strain, or maybe even a bacterial infection. With chronic, usually you're going to have this for longer than 3 weeks, and it could be from other things. So maybe you have polyps on your vocal cords, or maybe it's from some kind of inhaled irritant that you keep getting, you know, like smoke or allergens or something. Acid reflux is another big cause of this. So there's a lot of stuff like that. And then if you're a singer or someone like that who constantly uses their voice, you can have overuse of your voice, and that causes chronic laryngitis. So here's your risk factors. Again, infection, some kind of exposure to an irritating substance, or overuse of your voice. Things that you do to treat this, really, you're not going to treat it. You kind of just rest your voice and stuff, and then it gets better. Really, you're not going to treat it unless you know for sure it's caused from a bacteria. In that case, you would get an antibiotic, and that would help. If you're someone who uses their voice a lot and you need to kind of cut down the time that you're sick, sometimes they'll do a corticosteroid to help reduce vocal cord inflammation, and it might help you get quick a little faster, or get better a little faster. All right, so I'm not sure if in your chapter it talks about laryngeal cancer. I'm going to mention it here anyway. If you don't have it, you don't have it, but more information is better than none, I guess. So I'm just going to go ahead and go over this stuff with you as well. My other class, I know they have it in there, so that's why I have it here, but we'll just talk about it anyway. So laryngeal cancer is a disease in which you have malignant cells that form in the tissue of your larynx. Again, your larynx holds your vocal cords. That's how you have your voice. So risk factors include smoking, increased alcohol use, exposure to asbestos, paint fumes, chemicals, you name it. With signs and symptoms, you're going to have differences. So early on, you're not going to have as much, but then later signs are going to be more severe. So early on, you might just have hoarseness for a while, persistent cough, throat pain, or burning in your throat. Late signs, now as the cancer progresses, now you're going to have a harder time swallowing. You might have shortness of breath. You could have bad breath, unintentional weight loss, pain radiating to your ear, weird stuff like that. So the goals of treatment when you have laryngeal cancer is to try to preserve a safe, effective swallowing for this person, because you're hoping that they could still swallow without you having to do some type of intervention. You want them to still have a voice and try to avoid having a permanent tracheostomy if you can. So treatment that they usually will do is either going to involve surgery, radiation, or chemotherapy. So the prognosis is going to depend on the stage of the disease, the location and size of the tumor, and the grade of the tumor. The patient's age, gender, and general health, whether they're anemic, all of that kind of plays a part. So there's different types of surgery for this that you can do depending on what your tumor is like. So there's something called vocal cord stripping. This is where they remove the mucosa of the edge of the vocal cord using a microscope. So it's like a real tiny little surgery that they do. So obviously, if you just have like a nodule or something on your vocal cord, then this would probably be the thing to do. A chordectomy. This is excision of the vocal cord by laser, usually for lesions limited to the middle third of the vocal cord. Voice quality depends on how much is removed. So with this, they actually have to remove part of the vocal cord itself. So your voice is going to be different depending on how much they have to take out. Laser microsurgery is for surgical resection of small laryngeal carcinomas. You have fewer side effects and it's less costly than some of the other procedures. So this would be kind of a good one to do if you could get away with that. So if you have a small, tumor, that might be the thing to do. Okay, so partial laryngectomy. This is in early stages of the cancer in the glottic area when only one vocal cord is involved. It's associated with very high cure rate, and a portion of the larynx is removed, so part of your voice box, along with one vocal cord and the tumor. So the airway remains intact, which is good, and you don't have difficulty swallowing, but your voice can sound hoarse because, again, they've taken some of your vocal cords out and part of your larynx. So you would hope that you could do that if you could. Now, the total laryngectomy is a different story. It's a little bit more severe. With the total laryngectomy, you're going to have complete removal of your larynx. So listen to all the stuff that they take out. So the hyoid bone, the epiglottis, the cricoid cartilage, 2 of the 3 rings of your trachea, the tongue, the pharyngeal wall, and most of the trachea are left alone, thank God. But yeah, so you end up um, having permanent loss of your voice and a change in your airway. So now your airway's not going to be the same, and you have to have a permanent tracheostomy. So a laryngectomy tube can be left in the stoma. This kind of looks like a tracheostomy tube. You can tell them apart by whether the person can speak or not when you occlude the tube. If it's a laryngectomy tube, the person will be unable to speak or breathe when you occlude it. Usually they need a specific kind of prosthetic valve thing that they stick on there to help them speak without aspirating. So usually this is the best option for people when the tumor exceeds beyond the vocal cords, and it's also for cancer that reoccurs or persists after radiation. So, typically when you're to this point, it's pretty bad cancer. Okay, so after surgery, when someone has a total laryngectomy, some things that you want to keep in mind. Your biggest concern is their airway. So you want to maintain a patent airway. You don't want them to aspirate or have any issues like that. So you want them to sit up in a semi-Fowler's or Fowler's position. You would make sure that you do some tracheostomy care with their trach. So change that inner cannula every 8 hours. You're going to suction them and provide humidification, because if you don't, they're going to end up with a mucus plug, and that can cause, hypoxia. Because they don't have a voice anymore after this, you need to promote communication somehow. So maybe, before the surgery, you come up with a way with them. You say, hey, how do you want to communicate with me afterwards? And maybe they just want to write things down. So you provide them with a pad of paper and a pen so they can write things back and forth to you. Or maybe they use picture boards or whatever. Other things that we're going to be concerned about after surgery would be nutrition and hydration. So again, their airway is going to be messed up after this. So you have to promote nutrition and hydration by giving them IV fluids. You may have to do like some kind of tube feed for a while until they're able to, work with a speech therapist and try and get back on a diet of some sort. This is a huge surgery, and it can really affect your self-esteem and body image quite a bit. So you want to promote positive body image and self-esteem as much as you can. And then a lot of times, how, like before when we talked about colostomy bags and stuff, when someone has to do something like that, some people don't accept it very well, and they don't want to look at it or participate in their care. Same thing here. So you try to promote them to take care of it as much as possible. A couple other things I have in here is just a little bit about sleep apnea. Sleep apnea is going to be the cessation of breathing during sleep, usually caused by repetitive upper airway obstruction. Risk factors for that would be obesity. Usually males are more at risk than females, but females can still get it. Postmenopausal status, advanced age, people with a large neck, and also tonsillar hypertrophy, which means that you have big tonsils. Signs and symptoms, again, a lot of people associate this with snoring, but it's not necessarily just that. So frequent loud snoring with breathing cessation for 10 seconds or longer for at least 5 episodes per hour. Other things would be excessive daytime sleepiness, frequent nocturnal awakenings, insomnia, dysrhythmias, pulmonary hypertension, morning headaches. Usually they would have to do a sleep study for this to figure out that this person had it. When you go for a sleep study, they hook you up to all this stuff like an EEG machine. They do an EMG. They watch your leg movements, and they monitor your airflow and all kinds of stuff. So patients are told to try and lose weight. That's one of the first things they do, when they know they have sleep apnea, is they encourage that. Avoid alcohol if they can. Some devices are used to prevent people from sleeping on their back. So there are devices that can be put in the mouth to prevent the tongue from like falling backwards and collapsing the airway. And then of course there's CPAP and BiPAP machines that people can use. And then there's also a surgery. The surgery is crazy. Look at the name of it. Uvulo-palatopharyngoplasty. Huge deal. So what they do here is they take your tonsils out, but they also remove the uvula in the back of your throat and then part of the soft palate. They like shave it down. So this is a big deal, this surgery, and it can be very hard to take. The CPAP, if they do that, typically most people do the CPAP. This is continuous positive airway pressure. So what it is it's a machine that provides positive pressure using this mask. It keeps the airways open throughout the respiratory cycle and improves gas exchange in the alveoli. This is the most effective treatment for sleep apnea because the positive pressure acts as a splint to keep the upper airway open. All right, and then there's a picture of kind of what one looks like. And then with BiPAP, the BiPAP machine does two different things. So it will provide a set inspiratory pressure when inspiration takes place, and then it delivers a lower set expiratory pressure during exhalation. So this one is used more with people with bigger problems like COPD that require ventilatory assistance. So again, the CPAP, you're getting air pushed in to like kind of keep your airways open. But with the BiPAP, it helps with inspiration and expiration both. So it's different. And again, here's a machine just to give you an example. And then the last thing here I have is something about epistaxis, which again, I don't know if you have this in your stuff, but I'm just going to talk to you about it anyway. This is just another name for a nosebleed. So if you walk in and you see your patient having a nosebleed, typically the first thing you do is apply pressure, right? So you tell them to sit still, hold some pressure, and do it for at least 15 minutes if you can. The problem is so many people don't do it for 15 minutes and they're constantly like looking at their Kleenex and stuff. So usually they still are bleeding after that. So you always want this person to sit upright, head tilted forward instead of back. This prevents them from swallowing or aspirating their blood. And then if the bleeding doesn't stop, what you would do is usually you're going to call someone, probably a resident or someone, to come take a look at them. And sometimes what they could do, they might do some type of nasal decongestant, which can be a vasoconstrictor and hopefully get things to stop. Or they might, if they could see where the bleeder is at, they might try to cauterize it. They have like this little stick thing that almost looks like a match. And once they put it against the mucosa, it like burns that area and gets it to quit bleeding. So sometimes they'll do that. But if they can't figure out where the bleeding is coming from, then they're going to insert a tampon in the nose. So it's a, obviously the tampon would have like a little string off at the end of it. So this goes into the nose and then the string hangs out and you like usually tape it on their face. So this is going to stay in for 3 to 4 days. So before you put it in, sometimes they will, again, spray their nose with a decongestant. And then sometimes they'll put like petroleum jelly or something on the tampon itself so it goes in a little easier without causing a bunch of a discomfort. But yeah, so now this person's going to have this huge thing in their nose, and usually they have to breathe out of their mouth. So it's pretty crazy. All right, so that's that stuff. Then I just have one more topic I want to go over with you guys, because I know in your stuff it talked about a little bit about pneumonia. see if I can find that. All right, let me find my PowerPoint here. Okay, let me see if this will pop up. Okay, so I'm going to flip through to find my pneumonia here. So we can start with that. There we go. So basically, pneumonia is a lower respiratory tract infection that is caused by inflammation of those alveolar sacs in your lungs. Normally, your respiratory system can fight off different germs by filtering the air that's taken in through the nose. Like you have all those little cilia and stuff that kind of filters all of that. But sometimes certain things get through, and no matter what you do, and you just end up getting sick. So these germs will then go into the lungs by inhalation or aspiration even. Sometimes that's what happens. Or sometimes from a blood infection or whatever that just attacks the alveolar sacs. These sacs become really inflamed and then they start to fill with fluid. So your body's immune defense cell, it sends like red blood cells and white blood cells and bacteria that start to form there. So once you have all this fluid in your alveolar sacs, it's really hard for your gas exchange to occur between your blood and those alveoli. So this person ends up getting hypoxemia. So eventually with pneumonia, you can end up going into respiratory acidosis. So there's different types of pneumonia. There is something called community-acquired pneumonia, which is the one that you see most often. This is where a patient obtains the germs that cause the pneumonia outside of the healthcare system. So they just develop it outside the community. And then there's a hospital-acquired pneumonia. So this is a patient who's on maybe a mechanical ventilator, or they come in for something unrelated completely, and then 2 days later they develop symptoms of pneumonia. So that, 48 to 72 hours after admission, if they start getting symptoms of pneumonia, then it was, obtained while they were there. So like I say, I could have come in for a broken leg or something and I get pneumonia. So that's kind of where we're at with that. And then ventilator-assisted pneumonia is, hey, I have a ventilator in, because I'm in ICU or something, I can't breathe on my own. So the ventilator is breathing for me. But with a ventilator, you are intubated. You have this tube that's put in down your throat. And the problem is the longer it's in, the more of a chance you get for this, because bacteria can develop in your mouth and it can transfer to that tube and then it'll go down into your throat and cause pneumonia. So that's ventilator-assisted pneumonia. So typically they say if you give really good mouth care to people who are on ventilators, that helps a lot. And then anymore, we try to get people off the ventilator very quickly. We don't leave them on there for very long if we, can help it. And then aspiration pneumonia would be, something goes down the wrong pipe basically, and it gets into your lung. So sometimes people will, aspirate food, and then sometimes it's vomit, and you name it. All right, so signs and symptoms of pneumonia would be things like this. So we've got a productive cough. Usually, sometimes people will have pleuritic pain with their chest. So they get actual chest pain from coughing and stuff. Occasionally, if your pneumonia is really bad, you can have neuro changes. This would be especially with the older adults. So they may present differently with their pneumonia. So they could look confused. Elevated labs. So your CO2 count is going to be up. So it's going to be greater than 45 because you're retaining carbon dioxide because you can't get that good gas exchange with the alveoli. You're going to have increased white blood cell count. This usually will represent infection. Your breath sounds are either going to be like really diminished because you have so much fluid there that you can't hear any good gas exchange, or sometimes they'll sound like crackles because you have so much fluid there that you just hear that crackly sound. If someone's able to cough and like mobilize some of the secretions, sometimes you'll hear rhonchi. So it varies. It just depends on how bad your pneumonia is, on what you're hearing. You can have a mild fever with this, and sometimes it gets really bad and it can get really high. The oxygen saturation is going to be low, so you're going to need supplemental oxygen. Sometimes people will just feel really fatigued and they'll have anorexia where they won't want to eat, nausea, vomiting at times. You can have a high heart rate and high respirations with this. And then sometimes you'll have aching, like achy kind of joint pain. So that would be some other things you might see. So typically some of the things we could do for interventions for this would be, hey, first thing, incentive spirometer, right? So the incentive spirometer is actually going to help like pop open those alveoli. So as you get filled up with fluid with those alveoli, they kind of suck in a little bit. And plus that, and the amount of fluid in there is causing that decreased gas exchange. Excuse me. So if you have them do the incentive spirometer, it like pops open the alveoli, so hopefully you can have a better gas exchange. You're going to encourage 2 to 3 liters of fluid to be taken in if this patient is able to do that. If for some reason they have a restriction, like maybe they have congestive heart failure or something, then obviously no for that person. But lots of fluids kind of help, you know, especially when you have lots of secretions and stuff, it helps thin your secretions and helps you be able to cough that stuff out a little easier. Of course, up-to-date vaccinations are always good. So if they don't have a pneumonia or a flu vaccination, they need to be getting it. You need to educate people about not smoking, hand washing, trying to avoid other people who are sick, keep the head of the bed elevated so it's easier for them to breathe and to get rid of some of their secretions. A lot of times you're going to do breathing treatments and other respiratory therapy things. Chest percussion is a good thing, especially if you have those thick secretions. It helps break some of that up so you can either cough it out or suction it out. So yeah, that's pneumonia. And yeah, I think I'm going to stop there because I'm not quite sure what else is in your stuff. I know they have some things about like trachs and stuff, but you know, I'm going to kind of leave it here, I think. So that's going to be your stuff for week 8. And then I believe week 9, we don't have class either, so I'll record more for that. You guys, please go online onto Canvas still and do your discussion questions, and that way I can still at least give you attendance points for the week. If you have problems or questions regarding anything you're doing and Realize It or anything, I get it. I know Realize It is not optimal. I know there's problems with it, believe me. So if you come across a question that's wrong or something, there is a way for you to mark it, and then I should be able to see it, and then I can pass it on to other people to fix. So try to get in the habit of marking things that you see wrong, or telling me about it at least, so I can say something to people. As far as our test we just did, we're going to have some time off here, so I can't necessarily meet with you right away to go over that. So when we come back, I'll try to meet with you guys then to go over anything or do any kind of remediation we need to do. Again, you can always, email me and I'll get back to you. So that's totally fine. Thanks, guys. I hope you have a good rest of the week.